Hello and welcome back. This is the 5th video in the diabetes series, and I want to talk real quick about the different types of diabetes. We briefly discussed it in a previous video, but I wanted to go into a little bit more detail here. So I'm going to talk a little bit about the 3 main types of diabetes that we usually see, which are type 1, type 2, and gestational. There are a couple others that are much more rare, so I won't get into those. But the vast majority of diabetic patients are going to fit into one of these 3 categories. The first is type 1 diabetes. Now, type 1 diabetes used to be known as juvenile diabetes because it tends to affect younger people. It is an autoimmune disorder, and it destroys the cells in the pancreas that produce insulin. So patients with type 1 diabetes, they don't produce insulin. And so they require for their entire lives to be on insulin shots because unfortunately that's the only way that we can administer insulin. So type 1 diabetics tend to be thinner, although with the obesity epidemic that we're seeing a lot more type 1 diabetics that are overweight or obese. Same thing with type 2 diabetics. It used to be, in older people, but we're seeing an overlap now where type 2 diabetes is being diagnosed younger and younger. And type 2 diabetes, unlike type 1 diabetes, is the patients do produce insulin, but the cells do not respond to the insulin, and it usually has to do with a lot of things. Sometimes there's a family history of diabetes which contributes. Sometimes there are lifestyle factors at play, such as obesity, diet, exercise, having a more sedentary lifestyle. So we can't say for certain why some patients will get type 2 diabetes and others won't. Some patients are just more prone to it because of their family. But then again, we see a huge, that lifestyle plays a huge role in that as well. And like I said, the lines between type 1 and type 2 diabetes are being blurred more and more because we are seeing type 2 diabetes being diagnosed earlier. We're seeing type 1 diabetics that are overweight and obese, and we do see type 2 diabetics that progress to the point where they require insulin. So type 1 diabetes, although they are always insulin dependent, there are also type 2 diabetics that are insulin dependent as well. So we don't call it insulin dependent diabetes and non-insulin dependent diabetes anymore to differentiate between type 1 and type 2, because some type 2s are insulin dependent. The third type of diabetes that we frequently see is gestational diabetes, and it happens that during pregnancy, a lot of women may develop this, and so that's why pregnant women, usually around 20 to 24 weeks, they undergo an oral glucose tolerance test, which tests for gestational diabetes. And patients can become very, very insulin resistant during pregnancy. The good thing about gestational diabetes is that it clears up immediately after delivery. So it's like someone flipped a switch. Before delivery, they had gestational diabetes. After delivery, their blood sugars go back to normal. So it's a very quick process. However, we want to make sure with our gestational diabetic patients that we screen them after delivery, usually about 6 to 8 weeks later, for diabetes, because we don't want to mistake type 2 diabetes for gestational diabetes. If the patient actually has an underlying type 2 diabetes, we want to make sure that it is treated appropriately. But that's usually pretty quick. They can come into the office and do an oral glucose tolerance test, and that'll tell us for sure whether or not the patient has an underlying diabetes. The So basically, these three types of diabetes are the most common, but not everybody falls into one of these classifications, and sometimes we have a hard time knowing whether somebody is type 1 or type 2. Sometimes it's a clear-cut diagnosis just based on everything that we're seeing. But sometimes it's not. Sometimes, they might be like in their early 20s, but they're overweight, and then we think maybe they're type 2, and so they've been sent home on pills, but then they come back into the hospital in diabetic ketoacidosis, and so then it becomes a question, type 1 or type 2. So the safest thing to do with those patients is treat them like type 1 diabetics and put them on insulin, because otherwise they'll continue to come into the hospital with diabetic ketoacidosis, and we definitely do not want that. As always, if you have any questions, feel free to post them in the comment section and I'll answer those to the best of my ability. Make sure you share my videos with your friends and family, healthcare providers, nursing students, anybody you think that might benefit from it. And don't forget to subscribe to my channel. Thank you. I'll see you guys later.